This conference will now be recorded.
So it's a non-invasive, non-contact, two-dimensional imaging system initially, but it's now three-dimensional and provides high-resolution cross-sectional images. So imaging of the posterior and anterior segment structures are also possible. Now, what you have to understand by the word resolution is that people often confuse it with how clear the image is. It's not about how clear the image is. Resolution means it's a minimum distance between two structures that, like when we zoom it or when we analyze it, it's a minimum distance between two objects that can still be determined to say that these two objects are still different. भनेको दुईटा कुराको बीचमा हुने जुन the smallest distance that you can perceive or that the machine can detect for you to tell that these two structures are structurally or integrately they are different. Like, I mean, when you are trying to say that, that's the resolution, right? High definition is the resolution as well, but again, it also talks about much clarity. त्यसैले गर्दाखेरि don't confuse high definition or the resolution. High definition is something else. Resolution depends upon how the minimum distance between two objects at which you can still say that these two objects are different. So this I'm not going to talk about. Optical coherence tomography, it's basically an optical biopsy. It's a section, you take the sections of the retina, now even the choroid and the sclera. So why is it an optical biopsy? Is that, for example, in a case of diabetic retinopathy, you have the first indicative sign, but in the clinical fundus examination, that is your microaneurysms. So those microaneurysms can be detected using optical coherence tomography, and those microaneurysms can even be analyzed where they are, what the flow type is, using optical coherence tomography angiography. So that's a non-invasive optical biopsy. But same microaneurysms, when you are doing a biopsy at pathologically or histologically, you'll actually see that those microaneurysms corresponds to the earliest histologically evident damage in the eye, which is the loss of the pericytes and bulging of the microcapillaries in the prearterial and postvenular section. So since that can be detected without any invasive procedure, because if you want to see if it was really a microaneurysm or not, if you did not have an OCT, the only other way was to take out a piece or a small tissue of the retina and examine it under the microscope. But since we don't need to do that, it's basically optical biopsy. Why I am focusing more and more on the optical biopsy theory is that if you know all the layers of the retina, that is your histology. And what you see in the OCT is basically the same thing. So when you know all the layers, and for example, in the macula, the layers that are devoid, so what happens is you start knowing about your connections. For example, in the outer plexiform layer, you have more of the bipolar cells and the horizontal cells. The whole length, you have the Muller cells, and more towards the inner plexiforms, you have the amacrine cells. So when you know where the damage in the retina is by looking at the OCT, you should also be able to comprehend what actually is happening in the retina. So is that damage going to be a permanent damage, or is that damage going to be a temporary damage, or is it going to be a reversible or irreversible? So that is another point that you have to focus. So once you know the layers of the retina, is the same thing that you will be focusing in the OCT as well. So this I'm not going to discuss much about it. This is I think the classical Zeiss model. Then you have the Topcon, the Heidelberg. So this is a cross-sectional view of the OCT showing different layers of the retina. Again, it's the same thing, but again, what happens is while you are drawing your retina as a histological segment, you really don't see much of the new things, because right now there are certain things behind the rods and the cones, and just in front of the outer nuclear layer, which is now termed as the ISOS junction, which is also known as the ellipsoid layer. Ellipsoid layer has especially gained lots of attention in the recent OCT interpretation, because like the first thing is you order an OCT, but if the OCT is, for example, the most of the times the only reason why a clinician or anyone sends an OCT is to see if there is edema or if the RP is normal or not. And if that OCT, when it comes to your hand and you cannot see a edema, or you find that the RP is fine, but still the retina is not able to explain, the OCT image is still not able to explain the poor vision in the patient, then because you are not able to interpret the other layers properly, then the problem starts, because like you don't have any other investigating method except for doing an ERG or an EOG to to further confirm. So this, I think I don't need to describe it much. This is the vitreous side, this is the choroidal side. So in OCT, what happens is the picture that we usually have of the retina in our image, it's opposite here. So what happens, basically, I used to think when I was starting to read the OCTs, then you have the concept that you have the RPE, then you have this, but it starts from the other side, from the choroid, and it towards the vitreous. This you understand. But what happens in the OCT interpretation, this layer up to the inner nuclear layer is known just outside of the inner nuclear layer. This is known as a superficial retina. And these structures are called a deep retina. Why is it called the deep retina and the superficial retina is due to the vascular supply. I think if anyone has seen the OCT angiography images, that's how they are classified. They classify the layers which are more towards the internal limiting membrane as the superficial capillary plexus. The more deeper into the deep capillary plexus, the ISOS junctions and the RP as the avascular retina, and beyond that you start seeing the choroid. So although the retina, when you are just talking about the OCT, you will still say these are the inner layers and these are the outer layers. We're not talking about layers. These layers remain the same, but when you're talking about the capillary plexuses, or you want to comment about the microaneurysm, let's say there is a microaneurysm over here, then there is a microaneurysm over here. From our understanding, these are the outer retina, these are the inner retina. But when you are talking about vascular, you have to name this as the superficial capillary plexus, right? And the ones over here as the deep capillary plexuses. So when you're talking about the layers of the retina, you go with what you have learned. When you want to comment on any vascular pathologies, then you have to understand that the layers toward the internal limiting membrane are called the superficial capillary plexuses, because they're very superficial near the internal limiting membrane and near the vitreous, while the inner ones are known as the deep capillary plexuses. So why am I focusing on this is, I think most of us already know what all of these structures are. So this is rather confusing sometimes, like when you're trying to interpret, then this starts getting very confusing. So this you must understand. So over here, there are basically 4 to 5 bands of normally hyperreflective images that you will see. So this is also known as the heat map, while the black and white images are called the simple, the hypo and the hyperreflective, while this is a heat map. The heat map, what it does is the red ones are the hyperreflective, then you move from red towards the blue spectrum. So while you're going towards the blue spectrum, what happens is from a higher the area which is more hyperreflective towards the area which is more hyporeflective, then ultimately what happens is that once it cannot reflect anything, it starts turning to black. Because if you take into consideration this is a completely, if this is a completely hyporeflective and this is a completely hyperreflective, somewhere around here is a mixture of green and black, giving it a color of a little bit of a bluish hue, right? So what are the hyperreflective things which are normally found in the eye? That you have to understand, because once you know what are the normal structures, then only you will be able to find out what are the abnormal structures. So the normal structures, which are usually hyperreflective, are, as I said, are usually in a band of 4. So the first one is the Brooks, the other one is the RPE. Then after that, you start seeing the layer of the rods and the cones just above the RPE and their tails, because you have the rods and the cones, those are the photoreceptors. Then after that, you have the nucleus, and then you have the plexiform layer. So the nucleus, the band or the layer where there are plentiful of nucleuses, the nucleus always tend to be more hyperreflective. So this over here, they have started mentioning this layer as the ellipsoid zone, right? So this is where the IS, the internal segment, and the outer segment, they start forming connections. It does not mean that all of the connections are formed over there, but that's the areas where the connections are are made. So what happens is these tissues which are more towards the retina, they are more concerned about the signal transmission that is reached from the RPE, from the photoreceptor towards the nerve fiber layer. So as you move along, the areas where you find the nucleus layer, because you have the inner nuclear layer and the outer nuclear layer, you'll be able to find hyper-reflective areas as well. Now, why is this important is in certain retinal pathologies, when there is a complete splitting of two hyperreflective layers, it's like the mantra ones, any mantras though. When there is more splitting between any two hyperreflective layer, the prognosis are usually poor. So what happens? It's not just for here, for any layer. If there is a Brooks, there is a RPE, there is a space in between the Brooks and the RPE, two hyperreflective layers, the prognosis is usually bad. From the RPE, the rods and the cones, to the outer plexiform layer, the ellipsoid layer, if it has disappeared or there is a splitting, which we'll talk about later, then again the outcomes are poor. For example, if this patient has diabetes and it has macular edemas or spongiform or cystoid edemas, and those edemas are, if you see that they are likely causing splitting or separation of these two hyperreflective layers, then that means that eye is going to have a poor visual outcome. बुझ्नुपर्ने कुरा के भन्दा why I am saying that is all the hyperreflective layers contain some amount of nucleus. Let it be the rods and the cones, or the outer nuclear layer, or the inner nuclear layer. The nucleus, the cells that have the nucleus are the cells that do most of the signal processing. So in between these two signal processings, you have the plexiform layers. Plexiform layers are nothing but they are just like wires. They are just transmitting information from one center to another center. Now imagine these two nucleus, they have hyperreflective. In between, they have cables. For example, here, this is the plexiform layer. This is the inner plexiform layer, as you can see here. So these are basically wires. Now, if there is any pathology that is separating this plexiform layers, it's basically considering that this center and the center over here, the wire that is connecting these two centers have been cut off. So once these wires have been cut off, what happens is the signals that are created here, even if this patient has a completely fine RPE, completely fine the rods and the cones, completely normal IS-OS junction, but once over here you see there's a splitting in the plexiform layer. What happens? These signals, they cannot be transmitted beyond this layer. Although this part of the retina is fine, this and the RPE and the ganglion cell might be completely fine, the nerve fiber layer and the ganglion complex, but since the signal is not reaching the other side, there is a signal drop. Whatever message that the outer retina is trying to send to the inner retinas, the message is being dropped. So this signal cannot be transferred. Hence, this area will have a poor poor physiological and functional loss. Poor physiological or functional outcome. So now what happens is there might be a lesion just confined over here. Just because this lesion has caused a separation, you cannot overall say that the vision will be poor. If there are just few of these lesions which are separating these plexiform layers or the wires, then there are other still huge number of wires that are still connecting it to the outer connecting the outer retina to the inner retina. So most of the signals are still being transferred. So if only this amount of areas are split, that means there is still a chance of very good prognosis. But now if I start having all of this splittings, more the splittings, right, then more chances that this retina will start having a poorer visual prognosis. What happens is this edema, if you see it when the retina still has an active edema, then you consider it as a cystoid or spongiform. You either put a Avastin or a triamcinolone, and later on the retina completely comes back to normal shape. But you will start finding out that the vision is still not good in that patient, because what has happened was while the edema was present, the plexiform layers had already split. So although the retina comes back to its retina normal thickness, the the connections between the outer and the inner retina has already been disturbed. So this is a very, very important finding for you in all of the OCTs to analyze. Sometimes what happens, diabetic macular edema or some other pathology, then you have a vision of 160, 3 times Avastin. Retina is completely normal like this, but the vision is still 260. And then sometimes you cannot explain what is happening. And you do an FFA. When you do an FFA, you still see the foveolar vascular zone is normal. There is not even an ischemic maculopathy. So you have to take a look at the OCT slides that were present when the disease was active. Do you understand what I'm saying? Yes, I'm Buzeke, and if you have any questions, please ask me. Any questions that you have? Any questions? Should I move to the next slide?
If you have any questions, you can unmute yourself and ask to our
Please.
presenter.
These layers and everything, you already know it. The thing is, you have to know the interpretation. This you already know it. I don't have to focus more and more. And the hyper reflective things, so far I've only discussed about the physiological things. So interpretation is very, very important. So if you don't have any questions, I'm going to the next slide. So you have the various OCT scanning patterns, the line scan, the circle scan, radial scan, 5 raster, 3D scans. You already know it. So when do you use each of it, right? So there's a line scan, there's a circle scan, the radial scanning, the 5 raster, and the 3D scan. The 3D scan is the most commonly performed in any kind of OCT. The 5 raster, it's mainly in the Zeiss types. The radial scanning, it's very, very good, especially if you are thinking there are multiple areas of PED or multiple areas around the macula that are being involved by much larger spaces, because what happens is basically in radial scanning, the distances of the scanning are very huge, and sometimes what happens is if there is a huge edema or there's a huge serous detachment and you want to use a 3D scan, the number of the number of lines or the number of scans that need to be done are so many that when the final image is produced, it will produce a good image, but it will produce uh, an image, but you won't be able to analyze that image very much. You won't be able to get much information in such retinas. But instead, in a retina which has a large pathology, if you just take sections of it, then it will be easier. It's like, for example, when you have a retina that has a very small lesion just over here and you want to do a 5 raster, that's not a very good protocol, because like a single raster will take it here, then there's a certain around 3 or 5 sections. It depends upon the protocol. So what happens is between these two lines, the signal is not the scans are not very good, so you won't be able to make a very good interpretation about this, about a small lesion. For example, if there is a CSCR and you do a 1, 2, 3, 4, 5, there are 5 rasters, 7 rasters, 9 rasters. If you do it, what happens is it tends to make sections starting from the edge of the pathology right to the other end. And what happens is you are not wasting your time and you're not wasting your analysis on the areas which would otherwise be of the least importance, because like if you have the highest macular thickness over here and you're planning to do a full 3D scan of it, well, that could be helpful, but what information is it? What good information are you really going to get? Because it's just a CSCR. What difference would it make scanning the whole retina at just like 5 microns? Because like in a CSCR, the pathology is completely the same overall throughout. So what you do is you just do a simple 5 raster and take a sections. What happens is in those rasters, if you see that there are certain pathologies which you think could have been missed or you become suspicious of it, then you switch to 3D scan. The time taken for 5 rasters and 3D scan is very, very, 3D scans usually take a longer time. 5 rasters is a shorter time. And radial scanning, it's basically centered in the macula. And for example, if there are lots of radial scanning, it's basically when you have something like a macular fan or a macular star, it's very, very good, because it tends to scan at the directions of where there are certain things called the Henleys, the layers of Henle, which radiate around the macular area like a star, mainly due to the organizations of the outer plexiform layer. So the radial scans are very good at scanning all of those areas. Scanning and line scan, they're just protocols. So what I would do is, in a case of a CSCR, I would not want like first CSCR, vision is 6/9. I would not want to spend a lot of time doing a 3D scan, right? Doing a 3D scan and getting a report, because like even if I get the report of a 3D scan, what am I going to do is I'm just going to ask for a detailed image of only 2 or 3 spots in the whole of the retina. So when you're only planning 3 or 5 or this 3 or 5 spots of the whole of the retina, you don't want to use your time, extra time, to perform all the 3D scan. So 5 rasters, mainly in CSCRs and all of those things. So if the CSCR has resolved, right, and you want the patient to be checked if the central, you just want to focus on the fovea. If you just like, just take a snap of like not the scan of whole of retina, just one scan, or just one slice, then I'll just do a line scan that will directly be focused on the fovea. This way, what happens is all of the imaging property or all of the imaging resolutions of the OCT will be focused on only single plane, hence producing a very image of high resolution at a single spot. Because when you're doing a 3D scan or more scans, what happens, there are multiple scans occurring at each for example, the distance from here till here, if you have to scan it, like for example, if there are around let's say 512 slices of the retina that you are going to scan, and over each slice you're going to scan over 10,000 or 30,000 times, then what happens is you tend to lose your resolution. Instead of scanning the whole thing, if you're just focusing on a certain area of the retina and just scan it, what will happen is all of the efforts that is made by the machine to acquire the image will be only on a single plane of the retina, hence producing a greater resolution. It's similar to हाम्रो camera when we use a greater aperture and a smaller aperture. Smaller aperture, what happens? The area where you're just focusing, only that gets sharpened. The rest of the area, it's blurred, you do not care. But while you widen the aperture, what happens? You get larger area, you get to see a larger area of the background, but when you zoom it, you won't be able to see fine details of the area. So that is the main thing you have to understand in all of these scans. Also, for example, a circle scan, it's mostly used in optic discs, right? Even radial scanning is done in optic discs, while others, they're mostly performed in the analysis of the macula. So this, you see, there's the circle scans and there are the radial scans. So scan can vary, it can vary from 3 to 6. So it just depends upon the machine. These are all technical stuffs. So retinal thickness assessment is, what happens is, usually when you take a retina, the thickness of the retina, what it does is it measures the retina from the retinal pigment epithelium to the normally to the internal limiting membrane. So what happens, out of all the scans, it creates a volume, like a 3-dimensional structure which looks like this. Now what happens, the practice that we commonly do is we only tend to look at the central macular thickness. So if you have sent a patient to a central for a OCT, and you send for a central macular thickness and you get a central macular thickness of, let's say, 240, the patient is diabetic, then what you usually tend to think is that, okay, the macular thickness looks good. But the other thing that you have to take in mind is the macular volume. The macular volume, what happens in macular volume is, while the central macular thickness is only taken as a certain, just a single cross section and provides the highest resolution available for the around the foveal area, the volume will be calculated by same scans done multiple times over the area of the macula. So normally the volume of the macula is around 7.7 to 8 millimeter cubed. So in that retina where you see the central macular thickness of, let's say, 245, but if the macular volume is around 10.8 and that patient has just received 2 injections of Avastin and has clinically improved, and you think that the further injection of Avastin or anti-VEGFs is not required just because the central macular thickness is 245, then you are doing a wrong decision, because you're just looking at a single point. You have to look at the macular volume. If the overall macular volume is more than 8.0, 7.7 to 8 is normal. If it's more than 8, let's say it's a 9.6, 9.7, but the central macular thickness you get 245, the rest of the macula is still edematous. The inflammation is still going on. And if you stop Avastin or you stop your treatment at that stage, what happens is the patient will come back to you in 1 week with the central macular thickness, which is now thicker because the inflammation has now, from the rest of the macula, has spread towards the fovea and ultimately caused, again, the decrease in the vision. Now, the other thing that can happen is, for example, a patient who has a trauma to the eye and you have a central macular thickness of 245 and the patient comes to you and the vision is decreasing. It's around, it was 6/12 at presentation. At 1 month, it is 6/24. Another 5 months, the patient has now vision of 6/24. But as you do the OCT, and most of us have the habit of only analyzing the central macular thickness, and the central macular thickness might just show 245, 246, 247, or 244, but the decrease in the vision is not like explained. So over here, what could be happening is, while you're focusing on the central macular thickness and saying that it's a normal thickness, 245, the overall macula might be going into an atrophy and the macular volume could be decreasing. It could be 5.5, 6.6. So what is happening is, although the central macular thickness seems to be normal, the overall tissue around the macula is being atrophic, and hence the vision is deteriorating. So when you're interpreting the OCT, and especially it's called the macular cube, when you have the 512 by 128 scans over the 6x6 or usually 4.5 by 4.5, you also have to take into consideration that you have to look into the macular volume as well. So that will give you a clue of whether your even if the vision is good, even if your retina central foveal thickness has returned to normal, does the eye need further injections, or does the eye further need other treatments, or does the patient need to be explained of the prognosis that although the central fovea is normal, the area around the macula has been damaged and it's slowly shrinking. So these are the things that you must not forget to analyze and tell your patients, because I think most of the patients, most of you just look into the central macular thickness, right? Saurav. So, what is your opinion on that? Just scanning just taking 1 point and making most of, that's what I see. That's why most of the treatments are failing, because you don't take into consideration of the macular volume. So, what is your opinion on that?
Yeah, I definitely agree with you. But we can't just be focusing on the macro itself. Just in the foveal center, because the macro involvement in this kind of diseases, it's have to look at them as a whole. And because the inflammation is not just limited to the foveal center. We have that tendency, especially when we are in the learning phase, where we have that tendency to focus on the macular thickness, which is basically the foveal thickness. And we tend to overlook the other parts of the macula, which are equally important. And I definitely agree with you.
Yeah. So, anyone want to comment on this? like were you all aware that macular volume was also as equally important for determining further further intervention in that eye? Okay, and anyone have any questions regarding this? So now this is a color coding. The color coding at the that we discussed previously was about reflectiveness. Now don't confuse those color codings with the color codings of the thickness, fine? Because here what happens is blue black means thin, the white red means thick, and the green and the yellow are the medium thickness, right? So this is used for color coding, but again, the previously we discussed about one is about the reflectiveness of all of the layers, fine? So do not confuse the color coding that are used for the macular thickness with the color coding that is used to describe the reflective materials in the retina or in the macula. So uses of the posterior segment OCT, we all know is cystoid macular edema, macular holes, pseudoholes, epiretinal membrane, vitreoretinal retractions, central serous choroidopathies, retinoschisis, and retinal detachments. So to diagnose the cystoid macular edema, you have to know certain things like, I mean, where do you suspect a cystoid macular edema to form, you know? So it can range from inflammatory, traumatic, metabolic, right? Even post-cataract surgeries and all of those things. So usually what happens is not all patients are diabetic, but most of the patients that we encounter, they tend to go into the most likely, the most common intervention that we do is the cataract surgery. So especially what happens is cataract surgery in a diabetic patient. So following a cataract surgery, you already have a certain degree or a certain chance that some amounts of inflammation will occur due to the prostaglandins that are used, that are upregulated due to the trauma to the anterior segment of the eye during the surgery. So these prostaglandins, when they pass from the two main routes, that's via the transzonular, and the another one is via the episcleral vessels via the trabeculum meshwork. They tend to cause cystoid macular edema in certain populations, also known as the Irving gas syndrome, right? So, and this is especially of concern when you are doing a cataract surgery in a patient who has diabetic retinopathy and already a pre-existing macular edema with diabetic retinopathy, because you will have these kind of patients in your practice where the patient will have a diabetes, certain amount of diabetic edema, then you will have the cataract. So determining when to do the cataract surgery is quite easy when you look at the parameters like HbA1c, the sugar levels, urines, and all of those things. But from the surgical perspective, what you have to decide upon is when is the right time so that you do not flare up the macular edema. And as I was just saying before, a patient who have diabetes and want to do cataract, what happens is most of them are, what I see in most of the people who are practicing is they just do an OCT to see if there is a macular edema. The central macular thickness is completely fine. Then they send for cataract surgery. Then you have a macular edema with cystoid edemas. So again here in these patients, just looking at the central macular thickness just before the surgery is not a good practice. The macular volume should also be taken into consideration, because even if the CMT, it could be normal, the central macular thickness, if the macular volume is disturbed and is thicker, these eyes are likely to produce more a severe form of a post-operative cystoid edema, and hence not a very good like gain in vision or gain in letters post surgically. So these are the patients which I am very much concerned about when in the group where they have cystoid macular edema, because other pathologies, for example, you have a branch retinal vein occlusion or the central retinal vein occlusion, you already have the patient, your patient is already coming to you with a pathology. The patient already has a branch retinal vein occlusion, then cystoid macular edema is a result of the branch retinal vein occlusion. So you are already dealing with a pathology there. So the outcome, the disease, the outcome of the disease could go anywhere. And since the patient presented to you with low vision and mainly came to you to save whatever vision that is possible to save, because all of these pathologies, the number one criteria for any intervention is to preserve whatever sight or visual acuity, the best BCVA, the best corrected visual acuity that the patient has presented with, to save that amount of vision. That is the most important criteria. And if possible, improve the visual acuity following the treatment. So if you look at all of these cases, a case of central macular edema in a BRVO might be presenting to you with a 6/36. Not much to worry. A patient with macular holes 160, not much to worry. Epiretinal membrane 360 to 636. But in a patient who has diabetes but is mildly diabetic, does not have very much macular edema, because you did an OCT and found the central macular thickness is around 245, and you want to do a cataract surgery in this patient so that the patient can improve the vision from 624 to 6/9 or 6/6, and then you forget to look at the volume, and after doing the cataract surgery, you, instead of improving the vision, then the patient still has a 6/36 or even worse due to increase. Then these are the group of patients that can cause you trouble, because you don't do a cataract surgery to just save the vision that they have. Cataract surgeries are usually indicated to improve the vision. So if you have missed those kind of like retinal findings in the OCT, these kind of patients will especially cause you a lot of trouble. So always please consider the macular volume and the cystoid macular edema when you're looking at any OCT reports. So progression of these are also done for the progression of various other diseases that I don't need to mention. So when I request for an OCT, how do I do it? Because like what I see in most of the places is that you just say right eye OCT or right eye OCT macula. You just send it to the technician. But like, and what happens most of the time, the lesion is somewhere else, and the OCT scan, like, because the operator just needs, just wants to get the OCT done and create a report. He sends you the report, but the scan, the section of the scan is done elsewhere than where you have intended to look at. So when requesting for an OCT, always write an OCT, left or right eye, or do you want to get the OCT of the macula, the optic nerve, or both? Because you have the wide field OCT 12 mm sections where you can see the OCT of the macula and the optic nerve in a single section. Especially this is indicated in eyes with choroidal colobomas or optic pit maculopathy, or sometimes you also want to see the choroidal details as mentioned over here. So also I would like to say, do I want the OCT operator to focus on any specific lesion in the whole eye? Because like the vision could be 6/6, the macula could be completely fine, and at the end of the superotemporal artery, just over the arcade, but inside the posterior pole, there might be a PED or something like that. If I do not mention that there is a PED outside of the macular area, it's very, very likely that the operator is going to miss that lesion. So always mention if you have any specific lesion that you want to focus upon. Then you have the criteria, the option of scanning. Do you want to do a vertical scan or do you want to do a horizontal scan? Because what happens is, for example, if a lesion is like this and you are planning for a vertical scan, when this scan makes a cross section here, maybe not much information can be gathered. If it's just one nerve fiber layer or like a bundle which is just split, instead of doing this, if you combine it like that, you're covering multiple, you're covering a multiple areas of the same lesion to see how the lesion over here is differing from the lesion over here. Similarly, if the lesion is like this, if you're just taking a scan right over the lesion overall might just look the same. You won't be able to say if what is different. But when you take sections like this, we have multiple sections going perpendicular and having multiple cross sections of lesions. So when you analyze this in OCT, what happens is right next to the lesion, you are analyzing the lesion right next to the normal retinal tissues. So this way you can find out what exactly has happened at the junction of the normal retina and the abnormal retina. So this is especially helpful to, like, do you want to do a vertical scan or horizontal scan? Most of the time you send a scan. This is the horizontal scan is the most commonly performed one. And what happens is the scan just runs through the lesion and you cannot really determine anything. But if the same lesion was scanned on a vertical scan, then you would have multiple scans cross-sectioning it, and you would also be able to compare it, the lesion or the abnormal retina, directly to the normal retina just right beside it. So this also you have to keep in mind. Then the dimensions, 3x3, 4x4. So this is very important, because what happens is basically if you have consider this as an optic nerve, then you want to scan a lesion that is this huge. You just send for an OCT and the person just makes a scan that is 3x3. It makes no sense. This is already a damaged tissue. What do you want to do further looking at a damaged tissue? Always in an OCT, when you have a lesion, always make a habit as far as possible, because if the lesion is here, you might not be able to look, and always have the habit of looking into how the junction looks like, where the junctions of the abnormal and the normal tissue look like. When you compare the normal tissue with an abnormal retinal tissue right at the junction, what happens is, if this is the abnormal and this is the normal, you can analyze each of the layers directly to the corresponding retina, if this is the abnormal and this is the normal. So by doing that, you can compare which layer is having a problem. If there is any hyperreflective or hyperreflective areas that are increased or decreased, you can directly compare it to the normal. So the normal would be a good reference to to see what is going wrong in the abnormal retinal tissues. So that way you will be able to determine if that problem is mainly concerned with damage of the RPE, photoreceptor, retinal nerve fiber layer, or ganglion cell layer. So this is a very important thing about where you want to scan and how large you want the scan to be done. And multi-raster, 3D single raster radio, we already mentioned about this. And the most important thing is the comparison with the previous scan or the normal eye or the contralateral eye. What happens is, most of the time the patient, they come to you, they say Avastin was done 1 month back, they forgot their report, and you just say, okay, let's do an OCT today, let's see how it is. Then you just get a cross section of the status of the eye. That's how, how the eye is today, but you do not know how it was 1 month back. Has the eye really deteriorated, or has the eye improved, or is it getting worse? So if you just say compare it with a previous scan, the operator will immediately do a rescan of that eye with a previous scan, and at the same, if the patient has forgotten their report, they will print the previous and the current in the same with analysis suggesting what is happening to the macular thickness, what is happening to the overall macular volume, so you can plan correctly for the patient right at the moment at this visit. So that's how you, like, I mean, that's how I request for an OCT for all my cases. So you don't tend to miss, because sometimes you do an OCT, then, like, I mean, it's your mistake that you do not say do a OCT scan at the specific, and you get a report that does not have what you want to look at. Then you start just, you know, like, complaining or blaming the operator. The operator has completely I mean, he's completely pure, she's completely innocent about this. Like, I mean, it's your fault that you did not mention what needs to be done properly. So this is an overall OCT report. I mean, we have these are just other parameters which you do not really need to know. But what happens is, usually you have a fundus photo. This is a filter free. This is a red filter. So it highlights everything that is more red in color or white in color. The red things, they turn into dark. So when you have hemorrhages or anything, they are highly, you know, like, illustrated over here. So this that you see over here is called a shadowgram. Shadowgrams are images that are produced by the shadows of the structures, right? So what happens is, even if you are not able to find microaneurysms here, you might be able to find some of them here. But when you do a shadowgram, even the microaneurysms, because the resolution of the OCT is so good, the shadows, because it's a reflection, you see, you're using an OCT, you are sending a signal, and you're trying to get back, I mean, trying to see how much of your signals are getting back. So in that process, the vessels, the microaneurysms, any pathology that are there, they tend to cast small amount of shadows in the retina. Those shadows are caught back by the OCT, and anything like small microaneurysms or, you know, small lesions pathology, they could be highlighted in this shadowgram. And this is just the macular subfields, the ETDRS macular subfield, telling about the central thickness, the paramacular central thick. This is the foveal thickness, perifoveolar, and the macular. And over here you can see the three parameters. There are mainly the central macular thickness, the volume, and the average macular cube thickness. So it tells you about three things: the overall volume of the macula, the overall average thickness of the macula, and overall and the central macular thickness. So from here, what you can determine is, sometimes the eye can have a volume of 6.5 millimeter cube, and the vision could be 6 by 6. So in that case, what you do is you do a OCT, and you also compare the average thickness. If the overall average thickness of the retina is thin, in cases such as eyes with higher myopia or due to hereditary or genetic cause, what you need to do is now scan the contralateral eye. If both eyes give you a similar impression, then for that person, the volume 6.6, although it seems small, is the normal value for that eye. That's how you determine it. Fine. So moving forward, this is the macular thickness cube, where again the images are done to the blue, black, white, red, or the black. So what you just need to do is compare the macular scan with the thickness. So just by looking at it, I see that most of the macular area are in the green and the yellow zone, which is the normal over here. So I would suspect it to be somewhere around 320 or something like that, right? But if I take a look at this image and the image over here, it shows that the areas around here is a little bit thickened. Fine. Now, when you see that these areas are thickened, there could be some pathologies that are hiding over here. So what you have to do is you take a look at the normal retina, the the retina scan. This is the topography, right? So you don't see any areas that are corresponding to red areas over here, but most likely there's some edematous or a swelling that could be possibly over here. So what you do is, after you make this conclusion, you move to the OCT image, the cross sections, and over here you can see that there are multiple fine edema-like structures, cystoid spaces in the macular area. So this we'll discuss about it in the following slides as well. This is very atypical. You see, you do not have evenly distributed cystoid spaces all around the retina in a same plane. Do you understand? All of the cystoid edemas, most of it, are distributed along the same plane, just over the ISOS junction. Same thing happening over here, while the rest of the retina looks normal. So when you see something like this happening over a same layer, distributed evenly around the same layer, only two things can happen. Either it's a maculoschisis or it's some kind of a dystrophy, because dystrophies, they always tend to follow the germline and always tend to respect the layers. For example, in cornea, lattice, only stromal. You have the bucklers, then it's the Bowman's. So when a dystrophy of the lattice is occurring, it does not tend to affect the endothelium, or it does not tend to affect the Bowman's. It's restricted strictly to the stroma. But again, depending upon what kind of deposits are there, then you classify it further into various other pathologies. In cornea, same thing in the retina, where you see a lesion very, very, specific to a single layer, not affecting anything else. And even when the retina is so much affected, if this was a retina, I would imagine if it was caused by diabetes, and if that diabetic eye had this much of macular edemas, the thickness would not be as illustrated here. The thickness would be much, much greater, and we would be probably mapping this retina around the area of 400 to 500 between the yellow and the red. So this is the other clue the OCT images can provide to you in determining if that pathology is a dystrophic pathology, or is it a vascular, or is it some other retinal pathologies. So this can also give a clue. So, I mean, am I clear, or have you understood what I'm saying, everyone? Or is it confusing you? Is it confusing? You can unmute yourself, and you can say if you have understood it properly or not. So everything is, you've understood everything? All right, no questions then. So this is for the OCT of the glaucoma, which I just added, but I'm not going to much more details because we'll be much more discussing about the pathologies related to the retina. So this is a cystoid macular edema, right? So by looking at this image, you might think this is a cystoid macular edema, but look at the distribution. Only confined over here. The same bubbles, they are not going anywhere else. And over here, if you look closely, the cystoid spaces are slowly starting to split the fibers. these are the wires, you see. These are the plexiform layers, and the spaces between these plexiform layers is being occupied by the space. So consider this as a unit, the whole retina. The signals that are coming from the retinal pigment epithelium and the rods and the cones transmitted, trying to split, but I do not see a complete split because I think there's lots of connections still going on. So if I put a Avastin and this goes down, vision will be quite good. Here, some splitting, but still fibers are protected. The splitting has occurred between two reflective layers, the outer nucleus and the inner nucleus, right? And this is the macular region, and usually the macular region is limited just till the inner nuclear layers. In most of the cases, it does not extend beyond that. So in this case, right, what, like, again, please write it in the chat what each of you think will be the prognosis, what will be the visual outcome, and what will you suggest to this patient. You will say, of course, okay, you will give the patient an Avastin or something like that. And if the patient asks you, like, Dr. Saab Mero, like, what will be the outcome? So how would you rate the outcome for this eye? Also, the other things to be considered is over here, hyperreflective band is missing, meaning the rods and the cones in the fovea. Sorry, fovea does not have any rods, only the cones in the fovea. It's absent, right? There's something hyperreflective over here, which I would presume is a foveolar plaque, a hard exudates in the just in the subfoveolar cyst. So in this eye, what do you think would be the visual outcome? Can like, all of you just write what would be what do you think would be the visual outcome in this patient in the chat room, each one of you. What do you think will be the outcome? Will it be divided into, will it be an excellent outcome? Will it be an average outcome or a poor outcome? What do you think? Okay. What are the opinions of the others? I would like to hear from the others as well. Right. So yes, we have the opinions, and yes, like, I mean, you are correct. But what happens is, in my what I would say, and if you agree or don't disagree, you can write in the chat itself. We can just unmute and talk. What I would suggest is, till here, the RPs, the four rods and the cones looks normal. Here, between two hyperreflective areas, there are some splittings, but the splittings are not very much. The rest of the retina over here looks fine. So after and the foveal plaque is there, indicating a very poor outcome in vision. Over here as well, as mentioned, photoreceptor is missing. But if I put an Avastin in this, I would say this patient will have average vision, but this person will have a problem in the central vision. The perimacular areas are good, right? So in this patient, if the patient asks me what will be the vision, I would say the vision will improve, but you might have problem in central vision later on. You might see something black, or you might not be able to focus at what you are looking at. भन्छ नि नेपाली हामीले भन्दाखेरि हेर्दाखेरि बिचमा चाहिँ कालो देखे जस्तो देखिन्छ सेन्ट्रल भिजन चाहिँ नि it won't be there, it will be poorly, I mean the central vision will be quite poor, but overall vision there will be an improvement. I would rate it to a scale of on maybe an average. So do you agree or not? What do you say? Sort of, what do you say about this?
Yes, since the fovea seems to be involved more, so his central vision will be definitely be poor. And as you said, he will have some difficulty in the central vision. He'll
Yes,
complete the scrotum mass, and
exactly.
clearly it looks normal. Yeah, I was
Yeah.
especially about the central vision.
Exactly. This is the main thing that you all have to understand, because like this, what happens is when we look at this and we will just conclude that the vision will be very poor. But this is only for the central vision. When we're talking about the fovea, it's only corresponding to fovea, and maybe this area we're talking about maybe 10 degrees of the central vision. So central vision will be poor, most likely poor, but vision is likely to improve. And this is very important because when you have other pathologies, which is also like the age-related macular degenerations, all of the retinal pathologies, ultimately the end pathway is either a macular atrophy or they will present with a central macular edema. Now, depending upon how the rest of the retina is, how the rest of the layers of the retina is, because like this was the thing that I wanted to tell you all, because like so much we are focused on the layers and only on the macular area, we forget to look at the areas around the around the around the macular area. This is a cystoid layer here, 3 large cystoid spaces. So over here, it looks fairly normal. So in this, I will inject, and as suggested, average visual gain, poor central, poor central vision, because this patient, what will happen is injection, after you put the injection, the edema subsides, visual acuity gains, and the fovea, when it shrinks, then this patient will actually have a better visual acuity. So when they have a better visual acuity, the foveolar plaque that is right in the center and the loss of the photoreceptor layer right in the center, it starts becoming more evident to the patient, and it will, before, because they cannot see anything properly, they won't complain of like anything, they won't be, they will just say generalized blurring of vision. But when the edema subsides and this patient is able to see, because the rest of the retina starts functioning normally, they will say that although I'm seeing a little bit clearer than before, but I am seeing something black in the center of my eye. So that is something you have to explain to your patient before the treatment. All right. So after the injection, what happened? This was the outcome. So what would you say now? So what do you all think about the outcome? Do you still agree that the patient will have a poor central vision? Just write yes or no. Will the person still have a, because like as long as we're not interacting, right? I mean, it's no use me just telling you all of this. Okay, good. So just one opinion. Just a single opinion. So yes, the vision will be improve, but the central vision will be poor. Why? First, you have a problem here. Second, the foveolar dip has not formed very properly. This is not a normal fovea. The foveolar dip is still missing. So the patient will still complain of a central scotoma, right? So this image, why I have mentioned is if these are the photoreceptor layers, right? These are the nuclear. Then you have the connections, right? The connections are the plexiform. The horizontal connections, horizontal cells, vertical connections, bipolar cells, and ultimately you have the ganglions and the nerve fiber layers. So if the pathology occurs in between the spaces of the in between the spaces of the plexiform layer, what happens? Cystoid spaces start developing. And if you look at it properly, the cystoid spaces, they are spreading more like a radial pattern. So this is usually when the cystoid space is there, this is usually a horizontal, the vertical split where the edema slowly starts splitting the plexiform layer. While if the horizontal splits start occurring, as you can see in this image, when the horizontal splitting starts occurring, it causes schisis. So this is a schitic retina. So this retina is the difference between this retina and this retina is that if you do a visual field in this retina, due to the vertical splitting, the wires are not completely cut. There will be some relative scotoma, right? But here, since the splitting is horizontal, all the wires are cut. So there is no connection between this layer with the inner layers, and hence this eye will have a complete scotoma, absolute scotoma, while this eye will only have a relative scotoma. So depending upon if the edema has split it vertically or horizontally. Horizontally, it might not be edema, it could be hereditary or genetic, such as hereditary foveoschisis, retinoschisis syndrome, all of these things. So this you need to understand it very well. For example, if you take a look at this, the second hyperreflective band is missing. I do not see any communication with this layer of the retina right next to the fovea, huge spaces, right? And multiple splittings between the two hyperreflective bands. Hyperreflective bands are splitted completely. Very poor prognosis. Here, although splitted is there, they are taking various courses. Still some amount of communication is maintained. So this will likely have a better prognosis. So again, this is a central macular edema, right? So this, you can see that there, what is this? Can you please, type in the chat about what is this? What is this? Can you tell me what is this? Anyone? Is it different than what you're seeing? This is a CSCR. This is a PED. PED is a hyperreflective material leaving back some lower material of hyperreflective behind it. This is the Brooks pigment epithelial detachment. So this is a CSCR. Now, does this look like a CSCR? Was this present in the CSCR? So can you revise again? Is this a CSCR? What do you think? Asta Suwedi has said it's a CSCR, maybe. Manoj Mahat CSCR. Prativa has said central serous retinopathy. After I compare this image with this image, do you think the previous image is still CSCR? What do you think it is? What do you think it is? Okay, we'll come back to this slide again. So since you're confused with the CSCR, I'm going to the CSCR. Central serous retinopathy, or what we also call it central serous chorioretinopathy. You see the pigment epithelium, right? And you also see the layers of the rods and the cones. The pigment epithelium has detached, right? Here, and it has moved on. Beyond the PED, you see the whole of the retina. All the layers are intact. There is no intraretinal splitting. Since there are no intraretinal splitting, the prognosis of CSCR is usually good if it's not chronic, as long as it does not produce cystoid macular edema. If there is cystoid edema, cystoid means the splitting starts occurring. So this is a CSCR. Now this is a PED. The pigment epithelium has detached, right? So this is a pigment epithelial detachment, but this space in this space. What is A? What is B? Can you tell me what is A? What is B? Yes. Both are fluid. Both are fluid. But the space, what is, no, B is not air. What is this? This is the pigment epithelium here. Right. So A is the CSCR, while the B is the PED. What about this one? What is C? Good. So C is also a CSCR. So now if you take a look at this, what do you think it is? What do you think it is? What is this? What about D? Very nice, yes. Because you see hyperreflective layer here and then layer here. So this D, you have said CSCR. Now, I would just want to point out one thing. E and F. What is the difference between the reflectivity of E and the reflectivity of F? Which E or E is hyperreflect? Which is hyporeflective? Hyporeflective, E or F? Okay, good. And which is hyperreflective? All right. So if F is hyperreflective, do you think it is just plain water or serous fluid in the F? If it was just high water content, it would be like vitreous, where like 97 to 99% of the vitreous content is water. Here as well, it's just water, so it's just giving a hyperreflective impression. But here, I do not see any hyperreflective content. So do you think F is just clear fluid? So you see, although this looks like a CSCR, right? Although this looks like just like a CSCR, because the pigment epithelium is here, the rest of the retina is fine. The collection that is inside this space is a little bit different, right? So this needs comparison with the other eye. If other eye also has the same thing, then it could be a dystrophy called a vitelliform dystrophy. If this is just the same eye, just only one eye, and the patient gives a history of trauma, this could be a small subretinal hemorrhage. Do you understand? So this could be either, if this is how you correlate, because if you see this, if it's occurring at the both eye and there's a history of similar finding in the family and vision in both eye is quite same, then this could be a dystrophy. But if it's only in one eye, then the patient gives you a history of trauma, right? Then this could be a subretinal hemorrhage. Now, if the same patient has a fully blown, a large scar, which looks like a choroidal neovascularization membrane in the left eye, and has something similar in the right eye, this could be an early phase, a very early phase for age-related macular degeneration of wet variant, right? So it could be many findings, because like by just showing this OCT, I will not expect you to say this is a, even I will not be able to just say this is a, I cannot say this is the exact diagnosis, but I can say that this looks like there is a central serous retinal detachment, but the fluid is not clearly serous. There is also a mixture of some other things which is making hyperreflective material. So it could be a deposit of drusen space, drusenoid things, or it could be just blood. So there, I cannot go into the diagnosis right away by just looking at this. I need other clinically relevant images. So what I'm trying to say is you cannot use OCTs. While you can use OCT to make a very clear diagnosis in cases of purely ocular entities such as CSCR, you may not be able to use the same image to come to a diagnosis with a proper history or with help of further imaging. If I just take a fundus photo in these two pictures, if I see a red hemorrhage below, I could say there is a subretinal hemorrhage, but subretinal hemorrhage is not a diagnosis, it's a clinical finding. So what is causing the subretinal hemorrhage? Was it a trauma? Was it a CNV? I'll have to start searching for it. So I think CSCR, PED, CSCR, and other entities which look like CSCR, but they are not clearly CSCR, these you need to find them. I mean, you need to differentiate between all of them. right? So there are, again, this is a PED, not a CSCR. These are central macular cystoid macular edema. Over here, I also see some splitting, so also some foveoschisis is there. So this is the multiple pathologies over there. I just wanted to confuse you guys saying CME and only to focus over here. But there is a PED, right? There is a edema, and there's also foveoschisis over here. So it's multiple pathology. If you take a look at this retina, here, two layers can be seen. The junction is fine. These lesions, what are these? The bright two white lesions that you can see there, what are they? What are they? Can anyone tell me what are they? Anyone? So what you're seeing here as this hyper-reflective materials are hard exudates, right? We saw similar in this here. And I said there's a hard exudate just below the fovea, and it's called the foveal plaque. Here also it's the same thing. These are hard exudates over here. So this is cystoid macular edema. Again, well, the diagnosis is very simple. Cystoid macular edema. What caused the cystoid macular edema? Look in the fundus photo. Look in the retina. Is it a branch retinal vein occlusion? Is it a diabetes? Is it a central retinal vein occlusion? Then what do you do? Plan for treatment. What will be the vision of this patient? Since all the layers looks fine, I would say fairly good outcome in this patient. So this is how you approach a case, any case with cystoid macular edema. Now this is an epiretinal membrane. Fundus photo is very much required, right? So what happens is there are three different images. So this is an A, this is B, and this is C. So which is the most vision threatening over here? ABC, which is the most vision threatening? All right, C, yes. So because it's in the macula, right in the fovea, so what happens is it can snap off, right? It can snap off the central vision, and it can cause a macular hole. Over here, traction is present. This eye, the risk is that if the traction is too much, it might just rip off the retina over here, create a break, and this can go into a retinal detachment. Do you understand? So this can actually occur as well. A vitromacular traction can just get released. If it's not fovea threatening, you can just observe. But if there are certain things like this, you have to keep in mind that if this snaps off, right, you can create a break and the fluid starts going in, then you can have a retinal detachment. So that you need to make the patient aware of. The treatment for C is vitrectomy. You cannot do anything. There are certain things like ocreoplasmin and all those things. We do not use it here. In this eye, do not use Avastin. It will only make the Avastin or any anti-VEGFs, they make the vitromacular tractions and ERM just worse. In this case, observation over here, since the retina is already detached over here, you have to search for the breaks where the break is. Right? The other one is the macular hole, right? So macular hole, it's very easy, either the lamellar, the fullness macular hole, but the patient will often ask you, when do you want to do the surgery to the patient, and what would be the outcomes. So basically what you do is the distance between the ILM and the ILM, right? These cystoid spaces, the distance of the base, right? And the status of all the other bands that we discussed about. So if I were to do a surgery in this macular hole, what I would say is the surgery would be quite good since the hole is not huge, but vision recovery would be quite poor because the rods and cones disturbed, right? The ISOS junction is preserved. Over here, you cannot see ISOS junction, but as you see, it has bent upwards. So it's preserved because once it comes down, it'll create a communication. And overall, the once the ILM is inverted, we can have the macular hole closed. So it's overall it has a very good prognosis anatomically, but vision wise I cannot guarantee the patient with the central vision as I do not see the rods and the cones in the central area. Fine. So that's how you plan for treatment in the macular hole. For example, this macular hole, the patient has vision of 612, don't do anything. 618, don't do anything. 660, think about it. 360, 160, do the surgery. Because why I recommend 660, 612 to not to do the surgery is even after doing the surgery, the best visual outcome that you can provide in majority of the patient is around 612 to 618, or majority maybe 624 to 618. So in eyes which already have 612, you don't want to do the surgery, filling up with a gas, convert it into a PL or an HMI, then after the gas dissolves away in time, and the patient lands up with a vision of just 6/36. So that's not something you want. So again, vitreo-retinal tractions, see the macular edema. Then if the traction is too much, you have to do vitrectomy, right? Even if in this eye, somebody shows me this eye and says that the patient has vision of 618, I would still say that this eye needs to get vitrectomized early because of the traction. The splitting has started, you see, splittings has occurred. So later on, even after the surgery is done or this traction gets released, the splitting that has occurred can result in a like absolute scotoma of this eye. This we discussed. So just a little bit of the OCT findings, and this is an OCTA octa, which is also known as the OCT angiogram. So somebody asked me about what OCT I use in my practice. I use Topcon Triton DRI. So it's an OCT angiography with deep range imaging. So in a case of a CSCR, this is a CSCR, but there is something coming out from the choroid as well, right? And there are splitting of the plexiform layers. So overall, I can already say that this eye has relatively, like if I would have to score from 5, it would be somewhere around 3 to 2 for scoring this eye. So if I give an Avastin, this might get resolved, but there is a bump over here, which by just OCT, you won't be able to understand what that bump is caused by. But when you do an angio, you find out that there is a CNV. That's a choroidal neovascular membrane. So this looks like, although it looks like a CSCR, right? So CSCR is not purely a CSCR entirety. It's a CSCR resultant due to a choroidal neovascular membrane. And in such eye, as most of the like how we manage most of the CSCR by just giving anti-inflammatory NSAID, then stop smoking, then just observe. This will not work in this kind of CSCR since there is an active choroidal neovascular membrane which needs treatment with anti-VEGFs. So now coming to the ARMD, you see the pigment epithelium, they are detached, but there is something in between, right? So there are something in between. Now, if you look at this image, here you see basilar and lamellar deposits, something over here. So this looks like a drusen, and this looks like a PED, but the PED, this is not jet black as this. That means it is not a fluid filled space. It is something that matches the reflectivity of somewhere around here, or somewhere around here, somewhere around here. So I would say this is a PED, but it's a drusenoid PED. This is a pigment epithelium detachment, but it's a drusenoid. Also, when it is detached, always look into what is filling up the spaces in the retina, in the pockets where it's created. So here you see some things that are being filled. So this will be a drusenoid PED. If nothing was there, if it was very black in color, it would just be a serous PED. If there was no multiple but only a single PED, right? And the patient said the patient had trauma and there was a more hyperreflective, then it could be a subretinal hemorrhage. So this is how you distinguish between all of those things. Now here you see, in a case of a wet ARMD, again, cystoid macular edema is the end result. But over here, you can see that there are lesions arising from the Brooks and even from the choroid. So this is an age-related macular degeneration. This is a PED. What kind of PED do you think this is? There are 1, 2, there are 3. There's a large PED. Is this PED filled up with fluid? What do you think? What do you think? Is this PED filled up with fluid? Exactly. So that's a hemorrhagic PED. Very, very nice. So because as you can see, the blood is here, and just at the edge you can see a clear space right over here. So that's the empty space where there may be a clear fluid, but this is a hemorrhage here. So this needs a treatment. This is a wet ARMD, or a sign that a choroidal neovascularization has started. So this is the choroidal neovascularization here, hemorrhagic PED. Treat with injection. The membrane is gone. Now, based on only this OCT image, what most of the people would say is, okay, the hemorrhage is gone, right? The hemorrhage is gone. The PED has disappeared, so no more injections are required. Just go home. We'll see you later. But again, when I do an OCT angiography of this patient, right, what I find in this part is there is an active vascular. You see this? The pink layer. This is an Octa image. This is an OCTA, but you might not be very familiar. But soon this will replace all of the OCTs that you're practicing. So this indicates a blood flow. Pink is the choroidal blood flow. The red is the retinal blood flow. In this space, what you can see is, although this is the layer which divides the retina and the choroid, the pink is the choroidal blood flow. It is even getting, signals are of the blood flow, choroidal blood flow, are even being they are even appearing in the macular area, in the retinal area. So although initial 2 injections and getting a flat retina here, and you say stop treatment, but when you do an angio, you find that the lesion is still active, then if you had actually stopped the medication, then you would be doing a wrong decision. So this is how OCT angio can further aid in diagnosing and treating your cases. Fine? Because as long as this is there and you don't provide anti-VEGFs, the patient will return back to you with hemorrhage. Now, the same patient was treated with Avastin even after attaining a flat retina. Most of the people would say, what are you doing? The retina is already flat. The vision is already 6 by 36, right? Let's say the vision is already 6 by 36. The retina is already flat. Because if you are only allowed to see the OCT, if I just give you this image and I tell you that the patient also needs further Avastin, and I'm just continuing the patient in a monthly basis Avastin since 6 months, then you would probably think that I'm trying, or any doctor is trying to rob the patient because they are just injecting the Avastin in an eye which is already flat, but that is not what I'm looking for. If you look at the OCT NGO, the size of the CNV has gradually decreased over time, even if the even if the retina looks flat, vision is stable, and you would say stop if you just have a normal OCT. But since we are doing an NG-OCT, and I'm seeing that although this looks normal, the CNV is slowly regressing, I would continue my anti-VEGF injections in such cases so that I do not stop the patient from receiving the treatment that he needs. Fine. So this is how OCT angiography can help in your practice. So this is the PED, very simple here, right? Clearly fluid. Already discussed about it. Now this is the diabetic macular edema. Diabetic macular edema, how does it differ from other macular edemas? Is in diabetes you have something deposits like this. You have deposits like this, like this. These are all hard exudates, and hard exudates are characteristic, although not very specific, but they're characteristic for diabetic retinopathy because it is the presence of the hard exudates or the hemorrhages that upgrades the mild diabetic retinopathy into a moderate diabetic retinopathy. So when the criteria of the hard exudates and hemorrhages have been considered from upgrading the diagnosis from mild to moderate diabetic retinopathy, you cannot rule out, or you cannot just say hard exudates. You also see in other pathologies. So you cannot consider, you have to consider hard exudates in this as well. So this also has a macular edema with cystoid spaces, but you see that there are not much splittings, but I'm really concerned about this, which is right directly in the fovea, a plaque inside a cystoid space. So it could be a blood as well. It could be a hemorrhage inside the cystoid space. So we'd provide the treatment with injection Avastin in this, and ultimately the retina gets like this. So what do you think is the vision in this retina? If this retina had a vision of, let's say, 3/60, and after the injection I get this retina, what would be the visual acuity in this retina? Like, I mean, what would you normally consider for this? Give it in a range. What would be the vision? Okay, 6/12 to 6/9. Any few more? Few more? Okay, better than 6/18. Yes, better than 6/18, 6/12 to 6/9. So how do you decide is, although this was initially this was a risk factor and I thought that the patient would likely end up with a poor vision, this has completely healed, right? The retinal layers can be found, 1, 2, even the IS-OS junction is present. The other two hyperreflective layers are present, right? Initially, I do not see lots of splittings. The fovea dipping is there, not very prominent. So yeah, I would agree with anywhere above 6/18 to maybe 6/12, because the fovea dipping is not very very, like, it's not very distinct. So maybe somewhere around 6/18 to 6/12 is a good guess for this retina. So PDR OCT usually they do not have any advantage in PDR. Especially it's to figure out if there is a macular edema or tractions. For PDR, you can do an NGO. This is an FFA, or you can also do an OCT NGO. And for this, like, I mean, if the PDR with lot of traction membranes, go inside, do a vitrectomy, do a PRP, then put an anti-VEGF. No traction, just a PRP. There are new vessels just PRP. If there are new vessels and macular edema, first Avastin, because if in a case of a macular edema you are doing a laser, the edema just aggravates, and so in that case what you do is you do an inject an anti-VEGF. The anti-VEGF also helps in regressing the neovascularizations, and the edema also subsides, then followed by PRP. CRVO, look at this. The whole retina is destroyed. In CRVO, very, very less likely that the visual acuity will return to normal. The most we can plan is to stabilize the disease. Once the hemorrhages and the inflammation has subsided, perform a panretinal photocoagulation PRP to prevent neovascularization, and most likely the CRVO, they end up having a neovascular glaucoma. So doing a prophylactic PRP, it usually helps in cases of CRVO. So irrespective of what I want you to understand is, irrespective of whatever the pathology in the retina is, ultimately the final pathway is the cystoid macular edema. The cystoid macular edema, you will provide it with intravitreal injections or triamcinolone, but the main thing is what will be the outcome? What will be the response? Will the patient have a visual acuity, will a patient have a better visual acuity or not? So we have already discussed what you look into the OCT to determine if the patient will have a good visual acuity or not. Because either it's a CRVO, either it's a BRVO, either it's a macular edema and it's a CME, the treatment is the same. You do the anti-VEGFs, you give the triamcinolone, or anti-VEGFs or triamcinolone, you end up with lasers in some of the cases. But what you have to decide is the patient going to have any significant improvement in the vision or not by looking at the parameters that we have described in the OCT, right? So this is a BRVO, right? So this is a case of a BRVO. So here you see the reason why, because if the lesion is in this direction, right? So if I had taken a scan in this direction, all I would see was only this part, which I will not be able to determine anything. But here you see the direction of the scan is in this direction. So what has happened is, this retina is the normal retina here, the abnormal retina is here. So I'm being able to compare the normal retina with the abnormal retina. I can say, just by comparison, you see here the layers are good. I don't see any layers here. All the hyperreflective materials are better here. The hyperreflective materials are better here, but I cannot distinguish anything over here. So this is the importance of the direction of scanning. Either you want to scan the horizontal or you want to scan in the vertical way. So even in this is a cystoid edema. I cannot really say what the visual acuity will be at this moment, but after one injection of Avastin, when the edema subsides and when I'll be able to compare the normal with the insulted retina without the edema, when I look into the elements of the retina and compare after the edema resolves, then I might be able to tell what would be the outcome in this patient. Right? So this are some of the examples, right? This is just macular edema, diffuse macular edema. This and this is worse. Macular edema with traction, right? So again, after you inject with the injection here, now what you need to understand is, you see, volume 10.19, thickness 409, injection 270. You think that by looking at this, wow, it has improved a lot. But when you take a look at the volume, it has not decreased much, because although the center has decreased, these areas are still inflamed. These areas are still inflamed. So this retina will ultimately again go into the same state if not treated further, because when you take consideration in the macular volume, although here you see a decrease, the rest are still inflamed, and this part actually shows an increase in the edema. That's why macular volume is very, very important in determining the course of treatment, and not just relying on the central macular thickness. Fine. The same thing over here, right? From 491, 430, but look at the macular volume, 13.59 to 11.7. Still needs treatment, still needs treatment. 545, 315. You would think it's better, but look at the other parts. It's still high. The macular edema is still persisting. More treatment is required in the same eye. So this is a retinoschisis, as I mentioned earlier. It's now easier for you to understand. This is a normal retina. If the detachment and the splitting is occurring, but it's not occurring here, it's not occurring here, it's just allowing, like in the same plane. These are retinoschisis. Very, very poor prognosis. These people will ultimately, they will have a complete scotoma, and ultimately they will become like PL patients. So this has a very, very poor prognosis. And when the splitting occurs, the retina is very weak, because this can easily be snapped off from the rest of the retina. So in this retina, if there is some vitreous movement or vitreous traction, there you see, it can just snap off. Fine. So over here, if you just focus on this, it looks like a central macular edema. But if you focus over here and over here, then it becomes evident that this is not a central macular edema, but it's a retinoschisis. So these are some of the things. So I would like you to describe what you see in A and B. Please describe what you see in A and B, all of you. Because these images, they almost hold all the informations that we have analyzed till now. So in A and B, there's label 1 and 2. So what is A? What is B? What do you see? And what do you find in A and 1 and 2? Please write it down. Because with this, I will be concluding. So whatever you have understood, whatever we've discussed, it all sums up to this last image. So please tell me, please write down what you see in these two images. Those are different images. For now, I just want you to analyze, tell me about what you see here, and what you see here, and what do you see in 2, and what do you see in 1? Okay, CSR. 1 is CSR. 2 is P2. Okay, 1 is PED. 2 is CSCR. Do you think it's CSCR? What about the contents in the inside the? What do you think are these? It's not clear, you know. Here, they are not very hyperreflective. Actually, I see something hyperreflective over here. Hemorrhage. Okay. So here you see a subretinal hemorrhage, right? But it's not a hemorrhagic PED because the PED is occurring below here. There are lots of findings in this OCT. This is a PED occurring here. This is a PED here. This looks like a CSCR, but with a hemorrhage over here. This looks like a, what does this look like? What does 1 look like? Because if you see the retinal pigment epithelium, it has gone here and it's in continuity. So these are, although these look like PEDs, these are actually CSC. This is also CSCR, but from here, it's very difficult to tell if they are purely a CSCR or a PED, right? So what do you think is this? Because like you are seeing CSCR, you are seeing hemorrhage, you are seeing large spaces of PED. So these are all findings you see. These are all findings. You are not going into any diagnosis by saying this. So what do you think is the, like, I mean, what are some of the retinal disease that can, what are some of the retinal disease that can give you an, like, I mean, impression, something like this? Chits. What else? You know, I would say that this patient does not have any orogenital ulcers, or there is no neuropsychiatric or dermatological, I mean, component. So Behçet's ruled out. Okay, the patient can be diabetic. What do you want to do? I mean, this is the OCT that you get in a patient. So as I said, like, I mean, don't just rely on the OCT to get into the diagnosis. So what is it? Let me tell you a short history. A 72-year-old male presents to you with diminution of vision in both the eyes, but a sudden, more like, you know, abrupt diminution, loss of vision in the right eye since 4 days. The patient is diabetic, and the patient is also hypertensive. Blood pressure is not under very good control. Okay, so that's one retinal hypertensive retinopathy. Not really, but okay, that's the retina. Hey, now I'll give you another example of a 57-year-old female comes to you with bilateral diminution of vision associated with uveitis, poliosis. Then the patient also has AC cells of 3+, vitreous 2+. Then you see all of these findings. The patient also has tinnitus and like dermatological alopecia and vitiligo. Yeah, exactly. So this could be, but this could be a VKH as well. This could be a VKH as well. But this is not very, very characteristic of a VKH because VKH has a lump. It's called a lumpy bumpy, it's like a lumpy bumpy choroid. This, if you take a look at the Brooks, it looks normal. VKH is also it's mainly a disorder of the choriocapillaries. So in VKH, what happens is even this layer tends to go up and down. That would be your VKH. But here, since this is flat, and you see multiple PEDs, right? But you do not see anything here. If there was something like a hyperreflective material, you could say it was an ARMD, but this is flat, multiple PED, hypertensive, not controlled. I do not know whether if you've heard it or not. You've most probably heard of it. It's polypoidal choroidal vasculopathy. Have you heard of it? Have you all heard of it? PCV. Right? So after the injections, the retina, you turn into flat, and when you do a choroidal imaging, you find out that here you see the choroidal vessels dilating. These are mainly this area compared to this area. Here is granular. Over here you can see like big polyp-like pockets, right? So this are the polypoidal choroidal vasculopathy, where the vessels, they look like polyps in the choroid and they give impressions such as this. Fine. So I will just show you this slide. Tell me, actually this was a interesting case that we diagnosed when I was a resident. I was in, I think, second year when we wait a second. So take a look at this. Now, by just looking at this and the picture before, what will you diagnose this case as? You have CSCR, you have PEDs, the same woman, same history. Compare the choroid. In the previous slide, the choroid was almost straight. Here, look at the choroid. Choroid is also changing shapes and directions. So what is this? The Q. Anyone? Because this is like the most, like, rare, but like if you find it out, the diagnosis is, you can make like diagnosis in an instant in these cases. So what is it? Any guesses? 57-year-old female comes to you with same history, tinnitus, all of these things. So as I mentioned here, no uveitis features, choroid is near normal, lots of PEDs, lots of CSCRs, no uveitis, hypertensive patient. This was a PCV, or a polypoidal choroidal vasculopathy. Same thing, lots of uveitis, lots of CSCR, right? Then PED. Choroid is also disturbed. So this could be either, if there is a history of trauma, sympathetic ophthalmia, no history of trauma, it's a VKH. Now, the other most common diagnosis to distinguish VKH and sympathetic ophthalmia besides the history is rule out ocular tuberculosis. So in a similar image, if I show you, because this initially we thought it was a VKH and the patient received steroids, then later on I suspected something here. What is this? What is this? What is this? So this is a case of a no lumps, no bumps, right? No lumps and bumps, just simple PCV, lumps and bumps, VKH. This is a subretinal abscess. So this actually turned out to be a ocular tuberculosis. There you see this is a subretinal abscess. So these are some of the rare but yet very important OCT findings. So with that, I think we're concluding our OCT things. Like, I mean, I did take an extra hour of your class, but like, you know, like understanding only half of it and leaving, you know, the major portions of it, like, I mean, it would make complete no sense in analyzing the OCT because it's a vast topic. And so,
Thank you.
yeah, one away.
Thank you, Anadi, for such a wonderful presentation. We didn't feel bored focusing in whole 2 hours. I think most of our participants got what they were wanting or they were uh, considering during the OCT diagnosis. Hope they collected ample knowledge from today's presentation. Adding final note, I would like to request our faculty member Irana Da to add final comments, and then we'll conclude our today's session. Sorry if you are getting me. You can do your final remarks. Yes, sir. Thing is getting me. With this concluding note, I would like to thank Dr.Anadi Khatri on behalf of Nepal Optometry Student Society for such a wonderful lot of support and presentation. Thank you everyone for participating. Stay home, stay safe. Thank you.
All right, thank you, thank you. If you have any questions, you can just like ask, or like you can just send me an email. Because like OCT is like it's a very vast topic, but like just being able to identify central macular edema or this, it's not going to help you a lot. Like there are certain instances where you have to, you know, like there are certain findings which neither the books, neither like, you know, the people tell you, but it's very important that the main things, you know, like the hyperreflective areas, the spittings, and diagnosing PCV, the VKH, and the more rare ocular tuberculosis. These are all important. I think it was, I guess it was helpful for all of you. And like, I'm really sorry I took an extra 1 hour, but like, I really think that, you know, like you should understand the fundamentals of it, and I hope it was helpful for all of you.
Thank you, Zai. Thank you.